August Assembly and respected Chair. I thank AIOS, ARC for giving me this opportunity to take part in the debate. I'll be speaking in favor of the debate topic, that is community ophthalmology and private practice complement each other. So, community ophthalmology was described in actually in older eras as medicine promoting eye health and blindness prevention through programs utilizing methodologies of public health, community medicine, and ophthalmology. The new discipline was first proposed by Dr. Patricia in 1978 after observation of epidemic rates of preventable blindness among underserved population in urban areas of US. Public health or community ophthalmology, alternately they are called as community ophthalmology, public health ophthalmology, preventive ophthalmology, and it deals with the preventive, promotive, curative, and rehabilitative aspect. The failure of the private or hospital-based eye care to provide preventive services for at-risk population as evidenced by the high rates of blindness due to preventable causes. Moreover, the government institutional-based public health facilities were not equipped to prevent or treat the at-risk population because the system-wide infrastructure lacked the personnel capable of delivery of services. The transition of medical education in institutions to the era of community medical practice started from 1960. Alma Ata Declaration of Health for All by 2000 has specifically turned into Vision 2020 Right to Sight in 2000. At the dawn of 2020, we have reframed our agenda to universal healthcare. So reaching the unreached with an aim to provide affordable, accessible, and accountable eye care for each, both curable and incurable blindness is the trademark of public health or community ophthalmology. There were so many barriers or problems which were faced in implementing that because of limited literacy and lack of efficient manpower and infrastructure. Modern allopathic treatment of ocular morbidities became available during the colonial rule. After independence, the Indian National Trachoma Control Program was the first initiative, and then came the NPCB, that is, was implemented in 1976. So these are the stages. First is primordial prevention, where health education, environmental hygiene in case of trachoma, health dietary practices in case of vitamin A and other diseases. Primary prevention includes, examples are measles immunization, vitamin A supplement to pregnant women, prevent unhealthy birth practices. Secondary prevention is early detection and treatment, which lowers the established cases in the community, and screening for the cataract, glaucoma, and diabetic retinopathy. Tertiary prevention includes disability control and rehabilitation. So my emphasis is on community ophthalmology because it examines the problem with the respect to the population. It investigates the magnitude of problem, causes through surveys and studies, health facilities available, attitude of the people towards visual problem, and barriers responsible for that. Issues are thoroughly defined, solution sought, decision taken by stakeholder, keeping in touch with the stakeholders, and program ultimately implemented. And third stage is dissemination of the information to eye care providers and service users. Strategies, as we knew that at a planning level, we can start satellite hospital, mobile eye care unit, vision centers. We can train ophthalmologist, ophthalmic assistant, optometrist through public health. Advocacy can be done. So there is a difference between clinical ophthalmology and community ophthalmology, but they complement each other. How? The goal of clinical ophthalmology to treat individual, community is treatment and care of the community. Preventive approach, health education, and everything. Target here is single patient. In community ophthalmology, target is population or community as a whole. Therapy is surgery or medicine. Here in community ophthalmology, it is health education, counseling on top, along with surgery and all. So here you can compare both private and community. We can do much more for the community by implementing community aspect to our private practice also. So I am in favor of both. They complement each other. They are not mutually exclusive. And I rest my case here. Thank you so much. Thank you.